So today going to talk a bit about Mrcp basis consultation station, and we're going to discuss about multiple sclerosis case. So let's move on to our scenario. So this is Miss Emily Parker, a 30-year-old software developer, and she seeks consultation due to concerning neurological symptoms that have been impacting her daily life. She has no significant medical history or known allergies. There is no family history of neurological disorder. The symptoms have been ongoing for approximately 3 months with a gradual onset and occasional exacerbations. Okay, so this is your scenario, and from this scenario you can see that it is something to do with the neurology, and she is a young patient. So these two are the buzzwords for you. We're going to begin by the history-taking approach with suspected multiple sclerosis. So first of all, we're going to talk about the chief complaint and presenting symptoms. So you begin by asking Ms. Parker about her main reason for seeking consultation and elicit her primary concerns, focusing on symptoms that have been affecting her daily life. Then we're going to talk about the onset and progressions, explore the timeline of symptoms, how long she's having these symptoms, when did the fatigue begin, how did the visual disturbance manifest, and when did they first occur? Can she recall the onset of numbness and tingling in her legs? When did she first notice difficulty balancing? So these are all depending on the whatever the symptoms patient says. You have to explore it a bit more and ask about the onset and progression. Then we also want to explore the frequency and duration. So inquire about the frequency and duration of each symptom and determine if they are continuous or intermittent. We're going to ask about the triggers or aggravating factors. So ask Ms. Parker if certain activities or situation trigger or worsen her symptoms, especially in the case of a vision disturbance during prolonged computer use. We want to know about the associated systemic symptoms. So explore the presence of any other symptoms outside the neurological domain, such as headaches, fevers, or unintended weight loss. Impact on daily life. Well, we're going to assess the impact of these symptoms on Ms. Parker's daily activities, especially in terms of her occupation as a software developer. Occupational history. We understand the nature of her work, including the duration of computer use, deadlines, and any adjustments she has made due to symptoms. Lifestyle factors. We explore Ms. Parker's lifestyle, including exercise routine, sleep patterns, and stress level. Past medical history is very important, so inquire about any previous medical conditions, surgeries, or hospitalizations. Ask if she has a history of any autoimmune disorders or chronic illnesses. Medication history, we're going to discuss any medications, including over-the-counter drugs, supplements, or herbal remedies. Family history is equally important, especially the family history of neurological conditions or autoimmune disorders. Social history, we're going to explore about the social habits, including smoking, alcohol, and recreational drug use. Patient concerns and expectation. Don't miss this point in your consultation session. So allow Ms. Parker to express her concerns, fears and expectations from the consultation. So address any pre-existing beliefs or anxieties which are related to neurological conditions. Emotional impact, assess the emotional impact of her symptoms, especially considering the potential impact on her work and daily life. And use open-ended questions to encourage Ms. Parker to share additional details or concerns that might not have been covered. So I'll just give you it's just a framework of how we're going to explore the symptoms in a case of multiple sclerosis. You can apply it to any case actually. So try to remember these points. So if you use these points, you'll be able to take a complete history. What about the examination approach to the suspected multiple sclerosis consultation? We begin with the general examination. So we're going to look at Ms. Parker overall appearance, including signs of distress, fatigue, or any visible abnormalities. Second thing is we want to know about the vital signs. So measure the vital signs, including blood pressure, heart rate, respiratory rate, and temperature. Neurological examination. Then next, Perform detailed neurological examination to assess the motor, sensory, and coordination functions. Cranial nerves evaluate the visual acuity, visual field, extraocular movements, and fundoscopy. So in this case of multiple sclerosis, cranial nerves are very important, so don't miss them. In the motor system, we're going to check for the muscle strength, tone, and any signs of weakness or atrophy. And sensory system, we're going to assess the sensations, including the light, touch, pain, temperature, and proprioception. So all four modalities need to be checked. And we have to check the coordination as well, evaluate the coordination of fine motor skill through activities like finger, nose, finger testing, and test the deep tendon reflexes, including the patellar reflex and Achilles reflex. So this is about the neurological examination. Gait and balance assessment. Observe Ms. Parker's gait, looking for any signs of imbalance, unsteady steps, or difficulty walking, and perform tandem gait testing to assess the balance. Romberg test. Conduct the Romberg test to evaluate the proprioception and detect any worsening of balance with closed eyes. And coordination and fine motor skills. Assess coordination by having Ms. Parker perform tasks such as rapid alternative movements and finger tapping. Examination of the optic disc. If necessary, perform a more detailed examination of the optic disc using an ophthalmoscope to check for signs of optic neuritis. Musculoskeletal examination, so inspect the joint for any signs of inflammations or deformities, and we're going to assess the muscle strength and function, particularly in the extremities. Examination of the skin, inspect the skin for any rashes, lesions, or abnormalities that may provide additional clue, and perform a focused abdominal examination considering a history of abdominal pain or discomfort. An examination of the ears, re-evaluate the purpurated rashes on the external ears, and cranial nerve examination. This one we already have covered. So main in the examination is start with the general appearance, ask for any vital signs, do your neurological examination, and don't miss the gait and balance assessment in the Romberg test. And then if needed, if the patient has any eye signs and is suspecting optic neuritis, don't forget to do the fundoscopy, or at least offer it to the examiner that I want to do the fundoscopy. So differential diagnosis for suspected multiple sclerosis. We're going to think about it if there is reported symptoms and history of neurological disturbances. Especially if there is a relapsing remitting course. Remember that most common type of multiple sclerosis is the relapsing remitting symptoms. So if patient has relapsing remitting neurological symptoms, like they may say few months back they had some blurring of vision, some numbness in the extremities, some weakness of the extremities that has recovered, and now again patient has presented with new symptoms. So multiple sclerosis should be on the top of the list. Other differentials include acute disseminated encephalomyelitis. Now it is characterized by rapid onset of neurological symptoms. So often there is a history of viral infections or vaccination. Another differential is neuromyelitis optica, called Davick's disease. It primarily affects the optic nerve and spinal cord, so leading to symptoms such as optic neuritis and transverse myelitis. SLE, well, lupus can involve the nervous system, leading to various neurological symptoms. We all know that it's an autoimmune condition that can present with diverse manifestations. Other differentials include vasculitis. Certain types of vasculitis can affect the nervous system and causing the neurological deficit. CNS infections such as viral encephalitis or Lyme disease, it also may present with neurological symptoms. Migraine with aura. Some individuals may experience neurological symptoms resembling those of MS during a migraine aura. And functional neurological disorders, condition where symptoms are not explained by clear organic causes and may have psychological origin. Metabolic disorders, conditions like B12 deficiencies or metabolic disorders, they may mimic neurological symptoms. Sarcoidosis, it also can cause some neurological symptoms. JB syndrome, another differential, is acute, but remember this is acute onset and may be considered, although the chronic features of in this case makes it less likely. And finally, psychiatric conditions. Certain psychiatric conditions may present neurological symptoms, and a thorough evaluation is obviously needed to rule out the organic causes. So main differential to consider is acute disseminated encephalomyelitis, neuromyelitis optica, and she's a female, so SLE should be considered, vasculitis and CNS infections. But these are, I'm sure you all know how to differentiate these and what are the specific clinical features of all these conditions. So how you're going to present your case once you've done your history taking and you've done your examination. And remember that in consultation station, before going to the presentation, you must remember the eyes. Eyes ask about patient ideas, concerns, and expectations, and try to answer any questions which the patient may put. So I'm going to present your case to the examiner. First of all, going to do the introduction. Uh, Hello, good day, good morning, good afternoon, whatever you can say. My name is this, and I am a doctor at your whatever you can mention this or you can skip it. Today, I like to present the case of Miss Parker, whatever is the age, 30 years, 40 years, who present to our clinic with concerning neurological symptoms. So first of all, going to do the introduction and then identifying data. So she is a female known to our clinic with a history of whatever relevant history is there. And then you will move on to the chief complaint. She reported experiencing a variety of neurological symptoms, primarily involving her vision, balance, or sensory disturbances, whatever the symptoms are. So I'm just giving you the template. Obviously, it depends upon the multiple sclerosis patient can present with a variety of symptoms. So whatever symptoms are more important to the patient, you just have to mention them in the chief complaint. Then the history of present illness. In the history of present illness, the onset symptom was how long away. Then Ms. Parker reports a gradual progression of these symptoms over the past weeks or months, and she specifically complains of provide detailed information on the nature, thing, and evolution of the symptoms. So once you've done the history of present illness, then you'll move on to past medical history. So Ms. Parker has a history of diabetes, hypertension, or no history, and whatever medications she's taking, and there's no history of any other significant medical condition. Social history. So socially, going to talk talk about the patient occupation, living situation, lifestyle factors. Family history. There is no significant family history of neurological disorders or other pertinent condition. And so this is how you're going to further. So remember, in your presentation, the first part is your history, which you try to give all the details which you have taken from the patient, and then after that you move on to the examination findings. So on examination, I observed these findings. So in this, obviously, when you're going to do the examination, you may find some sensory impairment, you may find optic neuritis or any positive findings. Then you just mention the positive finding first in your examination findings. Investigations, further investigations, including like what investigations you want to do, like MRI, brain, lumbar puncture, and then going to move to the diagnosis. So diagnosis based on clinical presentation investigation, leading diagnosis at this point is multiple sclerosis, and considering the whatever the key diagnostic criteria is there. Management and plan. So Ms. Parker is currently under the care of, if she is under neurology, or what your management plan is, current interventions, medications, and referrals. You're going to refer to the neurology. You're going to do the further investigations like MRI to confirm the diagnosis and so on. So this is your framework for the case of the multiple sclerosis. I put some of the some of the questions which are commonly asked in the multiple sclerosis. So examiner may ask, can you describe the typical clinical features of multiple sclerosis? So one of the model answer is multiple sclerosis is characterized by demyelination of the central nervous system, so leading to a wide range of neurological symptoms, and common features include optic neuritis, sensory disturbance, motor weakness, and problems with coordination and balance. Another question, what are the key diagnostic criteria for multiple sclerosis? So remember this is called something called McDonald criteria. This is commonly used for diagnosis of multiple sclerosis, and these criteria require evidence of dissemination of lesions in space and time, typically demonstrated through clinical and imaging findings. And additional tests such as cerebrospinal fluid analysis and evoked potential may also support the diagnosis. So remember this criteria, McDonald criteria. How does multiple sclerosis impact patient quality of life, and what management strategies are employed? So multiple sclerosis can significantly affect a patient's daily life, leading to issues like mobility challenges, visual impairment, and fatigue. So management includes disease-modifying therapies to reduce the relapse, symptomatic treatment for a specific symptom, and comprehensive care involving physiotherapy, occupational therapy, and psychological support. Another question, what other conditions should we consider in the differential diagnosis of patient presenting with neurological symptoms? We have covered it already. However, one of the model answer is other conditions to consider include neuromyelitis optica, acute disseminated encephalomyelitis, and various autoimmune or inflammatory disorders. And in some cases, structural lesions or metabolic disorders may also present with similar symptoms. Okay. So it's also one of the questions, how do you approach long-term follow-up and monitoring of a patient with suspected multiple sclerosis? Long-term follow-up involves regular clinical assessment, imaging studies, and monitoring for disease progression or relapse. Close collaboration with a multidisciplinary team involving neurologists, rehabilitation specialists, and psychologists is crucial to address the evolving need of the patient. And finally, are there any red flags or warning signs that should prompt urgent intervention or investigation in a patient with suspected multiple sclerosis? So red flags may include sudden or severe worsening of symptoms, new onset seizures, or signs of potential complications such as infection. In such cases, prompt intervention, including hospitalization and further investigation, may be warranted. So, my dear doctors, this is end of my presentation. So, my whole idea is to give you some framework that how you should proceed if you came across a case of suspected multiple sclerosis. And these the questions are quite commonly asked by the examiner. So hopefully it will help you and in your preparation for the MRC cases. Thank you very much, dear doctors, and I see you in my next presentation.